So if we're ready, then we're
Yeah.
going to just move right into it. Are we good, Dr. Mayorga?
Everybody, I hope, well, you could probably still see me. I was going to stand up and stretch, but I was going to say, yeah, absolutely. Make sure you stand up and stretch, guys, because I think it'll be important. I don't want you, this is kind of one of my favorite topics to present on. So, again, I hope you guys will enjoy it. I'll start sharing the screen in just a second.
Sure.
There is audio on this one, so make sure, be mindful if there is a video embedded in this, and we'll have some questions as well. So here we go. You should be seeing my screen now. Is that right?
It is. We can see it.
Okay, great. So really, I think it's a really exciting topic. Again, I'm going to draw on some information now and really start looking at what we're talking about through the COVID-19 pandemic lens as well. Really kind of put that in. I'm going to do my best. I'm going to try to go quickly, and I apologize for that, only because I'm going to suspect you're going to have questions, and I want to answer those. So really, defining the safety net really, to me, is understanding population health, social determinants of health, and the role federally qualified health centers have played in all aspects of this. And so some of you may have heard me say this before, but I'm always a fan of fun facts, and I share this fun fact because it's always really impressive. But did you all know that every 2 minutes of energy that the sun puts out, that's enough to power the entire world in a year? And we absolutely know, right? The sun rises and sets every day. It's pretty darn consistent. But one of the things that I would hope could be just as consistent is really other things such as access to potable water, food, shelter, and let's put it out there, healthcare, right? Really, really important. So we hope that things are as consistent or as good as the sun that rises and sets. So we're going to go over 4 topics. We're going to go define population health. We're going to understand social determinants of health that I'm sure many of you tackled before or understood. I'm going to give you a quick history lesson on Fqhcs, and then I'll touch on UCI's one that you've had the pleasure of being in physically and working through. But maybe hear something new about our FQ. So, as always, I always like to start off with a quick question. This one's going to be really quick. It's just more a reflection more than anything else. But what is population health? What is population health? What does that mean to you all?
So this response is live on Poll Everywhere. My screen is shared. Once we get up to 5 responses, we'll start to look at what population health means to people.
It's a play on words, so feel free to move the words around.
All right, looks like we've started to get some responses coming in. That was a long response. We'll look at health from a broader perspective, looking at populations, the overall wellness of an entire community or communities. Health varies by population rather than by person. Physical, mental, emotional well-being of a community. An average level of health amongst a population. Epidemiology, herd immunity, social determinants of health. Looking into physical and social determinants of health of a specific population varying in sizes.
All wonderful answers. I mean, I couldn't say it better than myself, so I think we're done here, right? I think you guys did great. Absolutely, population health is all those things, and I think it's really important. I was mentioning earlier that it all depends on the lens that you look for or through, I should say. So population health refers to the health outcomes of a group of individuals, and how you defined those individuals is really important. Now, for example, right, when I was in private practice, I'm going to draw on that experience again, is I was assigned a population to me. As a family physician, I could take care of from 0 to 99 plus, and all those patients were my responsibility, if I saw them or if I did not. I was responsible for their overall health. Now, hospitals also take care of a specific population. They actually are responsible. They usually tell the state that they will, a catchment area, you hear that phrase in hospital settings, their catchment area is a certain number of zip codes within its radius. And here in California specifically, there's obviously lots of hospitals locally here in Orange County, and some of these overlap. Now, you continue to expand out. Orange County specifically, right? They are concerned about the overall population of the county. Now, what's also unique about Orange County's definition of population health, let's not forget, there's a lot of amusement parks in Orange County, you know, Disneyland, Knott's, and other things like the beach that draws in people from outside the county, even internationally. And so obviously the Orange County Healthcare Agency has a very unique lens on how they look at population health, more so now than ever, of course, with regards to the pandemic. But, you know, we can continue to kind of expand out, you know, obviously California being so broad, north, central, Southern California, all very unique spaces within the state, all very unique cities within the state that are really important to appreciate. And what's more important is how certain populations dictate how we will be healthy. And in essence, I will tell you that how well we care for one community will absolutely impact the way the other community or other city is going to be healthy. So to illustrate that, we're going to watch a quick video. Okay, so here goes the video.
What determines how long we'll live? Is it what we do? Is it who we are? Actually, when it comes to predicting how long you'll live, your zip code is more important than your genetic code. Here's how this works. Meet Deb and Maria. They both have jobs, they're around the same age, they're both married, and they both have 2 kids. Deb lives in A-Town, while Maria lives in Bville, less than 1 mile away. They're similar in so many ways, but here's the thing. On average, residents of Bville will die more than 15 years sooner than the residents of A-Town. Why? Because where you live is about more than just your address. It's about your opportunities. For example, Deb and Maria's access to healthy options is really different. In A-Town, Deb's family is surrounded by healthy food options, including farmers markets, specialty shops, and grocery stores. The air in A-Town is cleaner and fresher, and there are lots of safe, clean parks where Deb can exercise and her children can play. A-Town has good public schools for Deb's kids and easy access to emergency and preventive health care. On the other hand, Bville has broken, badly lit sidewalks, and the parks are unsafe. The air is filled with truck exhausts from the nearby highway. And for food options, Maria's only choices are Bville's many liquor stores, fast food places, or convenience stores. The schools in Bville are overcrowded and undersupported. And even if Maria can get her kids into better schools far away, she needs to figure out how to get them there without access to a car. So for Maria, having to juggle so much to find healthy options can be an overwhelming source of chronic stress, which is a serious health risk factor. In fact, for all the residents of Bville, chronic stress drives health problems like obesity, diabetes, asthma, and heart disease. How did A-Town and Bville get so different? Well, in many cases in cities and towns across California, the root cause was racial and economic discrimination. Over the generations, poor white people and people of color were pushed to less desirable parts of town, where banks refused to lend money, businesses left, jobs too, schools declined, and the neighborhood crumbled. Everyone who could move away did. And what's more, when communities like A-Town and Beeville are so unequal, Beeville isn't the only one that suffers. Because it turns out that not only is your zip code a predictor of how long you'll live, so is what country you live in. Countries with the greatest income inequality have the lowest life expectancy. So even Americans like Deb, who are white, insured, college-educated, and upper income, die younger than their peers in other countries. In fact, our life expectancy is 43rd in the world, and that number is slipping. In the end, our biggest health risk may actually be inequality, and extreme inequality hurts us all. So what do we do? Well, if we're all going to be healthier, we don't just need to help the folks in Beeville beat the odds. We need to change the odds for everyone. And that's what we're doing. There's a movement happening. We're Californians. We don't follow. We lead. We are building the power to make health happen in communities across the state. We are coming together to build one California, a smarter, more inclusive and equitable state that creates health and opportunity for all of us.
All right. Well, I mean, I've seen this video several times, and I think it continues to resonate now more than ever. The video is outdated. It's several years old now. It's about 4 years old. But we are now even lower on the life expectancy when it comes to compared to other nations. It's dropped year after year, and obviously the pandemic has really impacted that. Many of you probably heard that the pandemic even impacted disproportionately Black communities, Latinx communities versus white communities. And so it's really, really important to kind of put this all in context. In real life, we've been living this real life experience of how impactful social determinants of health have been. And so really, I think a lot of you on today understand this and could need some of this, but I want to make sure you appreciate the conditions and places where people live absolutely impact their overall risk of health. And I think that that's what makes this so impactful for me now than ever, as I've seen some of our community members suffer drastically compared to others. Remember, from one zip code to another, from one city boundary to another, this has really impacted us from the COVID-19 standpoint. And in the end, we would hope that we could really make a significant change on how things go. To this day, you know, we came off the conversation about Medicare and things of that nature, but remember, really your financial means dictates how well you'll have access to certain things. That still holds so true. And so the mortality risk of someone is 2 to 3 times higher if you come from a socioeconomically disadvantaged space. And so, again, I always like to show this picture because it's so impactful to me as a family physician. If I tell my patients to go and eat healthy, they may not even have that fork in the road. They may not have that option. They may have to go further. They may have to get on multiple buses to get to that store so that they could buy healthy food options, because the closest thing to them is probably a fast food restaurant. And so we want to curtail this, we want to turn this around, but it takes time. Everything takes time. And so we just need more advocates. And I hope, again, one of the bigger takeaways from today's discussion is that you help me be advocates for our patients and our communities. So the video obviously highlights some things, but I always like to share these next slides with folks because this makes it more real, it makes it more concrete. And I'll kind of pull in the pandemic in a second. But, you know, those of you who are at UCI know that these probably pretty well. And so these cities are adjacent to each other. But yet the Public Health Institute Healthy Disadvantage Index tool describes some really impactful things of how poverty is uniquely different, incomes are dramatically different, and of course, because having money is tied to insurance status, you would not be surprised that the insurance rate is a lot higher. But then you start breaking it down and who lives in these cities, you could see the difference on that. But just like the video highlighted, this is what always is impactful to me about this slide. There is literally a 6-year swing on life expectancy. If I raise my 3 daughters in Costa Mesa and I have this structure, they will do 6 years of their life compared to those in Newport Beach. And so if I grew up and raised my family there, that's what that last line means. And so it's absolutely disheartening when you see this, because this is the city. These are it. It is a street light. It's not a river. It's not a railroad track. It's not being on the other side of the tracks. You're not on the other side of the freeway. It's a street light that separates these two data sets. And so this is why it's super important that you all kind of appreciate the people in and around our communities. I don't have to convince you, I'm sure, but I think, again, appreciating how complex things are when it comes to someone's health. And so when we talk about the COVID-19 pandemic, early in the pandemic, the vast majority of the people who had access to testing were in affluent cities. Matter of fact, I would say some of the earlier cases predominantly were identified in Irvine. Well, all the while what was bubbling up until it was an explosion, literally, was here in Santa Ana and Anaheim, where most of the cases were eventually found. And so what was so disheartening to me was all of us trying our darnest to try to care for the population, while all the while different cities in this county were not able to appreciate what was happening. And so when you look at Orange County, the vast majority of the patients are not Latinx. They're only 35%, but yet 47% of them, of the cases, were Latinx. Those dying from this is 38%, unfortunately. And the most two densely populated cities, we're sitting in Anaheim and Santa Ana, where the vast majority, 20% of the Orange County community lives in, predominantly of Latinx descent. So again, 43% of all Orange County COVID-19 cases reside in these two cities. Is there a question? Sorry, I don't know if there was or not.
I'm just adding some details that it houses a lot of Orange County's Black population too, and that you will be giving a completely separate lecture specifically dedicated on the intersection of the Latinx community and identity and COVID. So.
Yeah, thanks, Kelly. Sorry about that. Again, I could get caught up in this fairly quickly, so I appreciate that. But I did want to share these slides just in case folks don't join that. So this is why it was important. But again, one of the biggest things that impacted these two cities is to kind of appreciate why is the case. Just like the video highlights, it was densely populated. The folks living in there were not working remotely. As a matter of fact, they can't. They were deemed essential workers. They have living constraints that live multiple generations within a household. So isolating someone with COVID-19 is very, very difficult. And again, the levels of poverty were extremely high. So I think those are the other pieces to drive home. So I think with that, I want to pose a question to you all. Reese will pop up the question for you, but apologize for the question stem, but what is the least influential contribution to your overall health? So think about it from your perspective. What do you think is the least influential contribution to your overall health? And then we'll kind of talk about what the data shows.
So our responses are coming in, and let's see. 50% said health-specific behaviors, 33% said healthcare access, and 10%, it's changed. 2/3 say health-specific behaviors, 20% healthcare, and then 10% physical environment. All
right, so let's jump in, okay? So what is the least influential? So this research still holds true. I think that the information you're going to see is from 2014. So what goes into our health? So what goes into our health? About 40% of what goes into our health is socioeconomic driven. So do we have good access to health care, a good paying, stabilized job, good family support, good income, community safety, all those things are really, really important, and about 40% of that makes up of us being healthy. 10% is physical environment. So what do I mean by that? Well, you know, I mentioned about, you know, access or living near train tracks, or let alone if you live next to a freeway, you have a higher propensity and risk of developing asthma or a chronic obstructive pulmonary disease because of the sheer volume of pollution that drives by you every day versus those who don't live by it. So that's a really important point. That's why physical environment plays a huge role. And then the other piece that was part of the question stem is, well, what about behaviors? If you partake in risky behaviors, that's about 30%. So if you smoke, don't eat well, have poor exercise habits, you know, consume more than you should with it causes, or have high risk behavior sexually, that really drives higher risk and overall impacts your health. So take a look at the percentage. Just do the quick math. That's 80%. 80% of what goes into our health has nothing to do with what I was trained to do in medical school, which is to understand the physiology and the pathophysiology of health and what makes someone sick. Unlike your training, I think you guys are getting this exposure now more than ever, which is fantastic, but a lot of this was never brought to my attention until much later. So only 20% of what I would call healthcare access and quality is really important. And I always like to draw a really interesting analogy here. So that 20%, think about it this way. What is access to care and what is quality to care? From a patient perspective, let me give you real life example. So when I was an IPA medical director, I was responsible for overseeing 400 PCPs and approximately 900 specialists that contracted with our HMO. Not all those doctors practice evidence-based. As a matter of fact, some still to this day will charge someone $300 to $400 for a diagnosis of a viral syndrome and give them 3 injections, a ceftriaxone antibiotic injection, a steroid injection, and a vitamin B12 injection. And for those of you in the audience that are in medicine or medical school, know for a fact that that is not how you treat a viral illness. But yet, there are doctors in this community charging patients, community members, that dollar amount for care. They walk into our Fqhc, we make the same diagnosis, and at the most, if they have the ability to pay, that same uninsured patient would have paid $35 for us to tell them how to do supportive care. From a patient's perspective, what does it mean to what quality and access is? Because they just spent a few months ago probably $300 to $400, and now they just paid $35 for the same diagnosis. So again, really interesting dynamics on healthcare, what goes into our health when we talk about these things, and really start talking about what's equality, equity, and things of that nature. So many of you seen these photos before, but I always like to share them because I think they always kind of make really interesting analogies. You know, the barriers, the wall, people of different sizes in this case, but equality is everyone is different but faces the same barriers, right? So that's kind of the concept. Equity is assuming everyone is different but has the same resources to overcome that barrier. But our reality is here. Our reality has been here. Our reality has been here during this pandemic. Some people have, and those others don't have any. And some of us start in a very worst case, worst situation. And the way I'll draw on it is that person that's there in the ditch is probably someone who's had ongoing active chronic medical conditions that have made them susceptible to having worse outcomes from COVID-19, all tied to their overall social determinants of health. Okay, so that's a really important thing. So our goal really is to try to eliminate that barrier, right? So what's going on right now actively? We eliminated the barrier. Think about this. We've eliminated the cost to receive a vaccine. So that is removing a barrier to real life, guys. Really, really exciting to see when things are actively done correctly from a health perspective, what could really happen. We are vaccinating millions of people a day, 3 to 3.5 million people a day, and they don't have to pay a dime for a vaccine. So really cool stuff. So now, transitioning on how we deal with social determinants, how we healthcare justice, all those things are really important. So who's been doing this for some time? So let's kind of walk through that. We're going to run through a quick true or false questionnaire with Reese here on the various concepts of a community health center, also known as a federally qualified health center. So go ahead, Reese, why don't you put those up? True, false questions. There's 4 of them.
All right, so we started to get some responses coming in. Going to hold off on sharing my screen until we get a few more, because I unfortunately don't know how to not share all the results right now. And I don't want to give it away. But all right, so we have 2 people who are done and 7 people who have started. So once the 7 are through, I'll share them.
Okay. All right.
All right, so I'm going to start sharing my screen. Everyone can toggle through. So for our first question, 20% for community health centers are considered the last result for healthcare access. 20% said true, 80% said false. Community centers are only serve low-income, uninsured, or underinsured patients. Our split is about 1/3 true, 2/3 false. For community health centers only provide primary care, we have 75%, so 3/4 who say false and 1/4 that say true. And then for our fourth question, the direction of the community health center is dictated by the CEO. Also about a 1/4 to 3/4 saying false split.
Okay, all right, thanks. All right, so let's find out how true or false some of these statements are. So, hey, look, it's a familiar photo for those of you who were caught the last lecture. Again, back in January 1964, the State of the Union address given by President Johnson was labeled after the fact the war on poverty because about 19% of the U.S. population was living in poverty. And one of the things he highlighted during the speech was the fact that there were a need to expand healthcare services to underserved communities. And he put forth something known as the Economic Opportunity Act that gave birth to federally qualified health centers, also known as community health centers across this nation. And so it was a really exciting moment to be able to offer access to care for those that were really in need, particularly having to drive miles upon miles to get to access. But the exciting part about community health centers, because the model of care driven by community health centers or FQHCs didn't originate here in the U.S. As a matter of fact, let's take you back a little further in history. Back in 1940, Doctors Karks were tasked with caring for a Zulu tribe nation in South Africa. And what they decided to do back in 1940 was to pose a really important question. They asked the tribal leaders of the community there, what was it they needed to stay healthy? What could they do as physicians to help their tribe stay healthy and not succumb to illness? And so this was a huge paradigm shift in healthcare. Think about what was going on in 1940. That did not exist. And so this was such a huge shift. People from all over the world came to train here, including Dr. Jack Geiger, who is now known as the father of community health centers, FQHCs. And if you look at his quote isn't referencing how to make sure you do the right prescription for hypertension or diabetes. He is talking about social change. He is talking about social inequities and addressing those needs of the most disenfranchised communities out there. So Dr. Jack Geiger unfortunately passed away, not due to COVID, but due to other issues just this past year. But again, monumental figure in the community health center realm. So what are FQHCs? What are federally qualified health centers? Well, if you've seen one FQHC, you've only seen one. They're all really unique, but they have a general mission. We will provide care to anyone, even if they don't have the ability to pay. Appreciate that statement, because this is a federally funded organization. So even if you are not here legally, you still will be given care here. It is an absolute interesting, thought, right? Because that is our purpose. If you don't have the ability to pay, we will care for you. We are physically located in medically underserved areas. And I always tell folks, sometimes you don't have to go do international mission trips. You just need to find the right FQHC that calls to you to want to work there, because every FQHC targets very unique populations across this entire country. It is led by a board of directors. That board of directors is made up of 51% consumers or patient board members, just like Dr. Karks, right? We mentioned that earlier. That's how FQHCs are structured. 51% of the board members are actual consumers and patients. So they tell me how and what direction we should move this, overall FQHC. We provide all sorts of services as a collective group. Some of us do, obviously, medical care, oral, behavioral, vision, social health services. In the scheme of FQHCs, OBGYN is not considered a specialty. It's actually considered primary care. So that's how the services we all provide. There's approximately a little over 1,300 FQHCs across the country, each ranging in different size. Some have 20 locations, others have just 2, like ours. But some have mobile units, others are embedded in shelters or in migrant camp focus. So very unique. But there's not a single state or territory in the United States that doesn't have an FQHC. So in some states, the vast majority of healthcare is delivered by an FQHC, believe it or not. So I will tell you this: every congresswoman and man knows who their FQHCs are. Okay, so that's also a really important point, because we are constantly advocating for our patients all the way up to health, to the state and to the federal government. We've cared for a lot of people. We just submitted our data for the 2020 tabulation calendar year, but this is how many people were served for FQHCs. From a quality perspective, we do really great quality of care. When you compare our ability to care for patients to those taking care of the same population, remember, these populations are medically underserved, social determinants, dramatically impacting their overall health. We do diabetes, hypertension, congestive heart failure, coronary artery disease better. We provide more preventative care. We have better access to screenings, as well as we immunize our children more quickly and up to date compared to others. The last topic there of low birth weights, because we have early entry into prenatal care, our babies are born healthier, as well as moms are healthier once they give birth and postpartum. So a lot of great things that go on at an FQHC. We are expected to follow evidence-based care. Remember I mentioned earlier quality of care? What is quality of care? We are expected to follow evidence-based guidelines in a culturally sensitive manner, and that's why we do such great work. And all this data has been collected since the 1970s. From a cost perspective, the cost perspective is always really interesting, because you think it takes a lot of money to care for individuals. We are cheaper per visit, about $1, and about almost $1,300 worth in savings. Now that savings is tabulated of stopping or mitigating emergency use utilization. So when you do the math, 1,300 times that 30 million, we are saving the healthcare industry, the government, $35 billion in savings. We're saving that much money. We could do a lot with $35 billion. So again, very unique, very interesting that since the mid-1970s, we've been doing care within these organizations, what I always like to say, the best kept secret in healthcare, and doing it extremely, extremely well. So what about our FQHC here at UCI? So we have 2 locations. Just to give you a calendar timeline, our first site came online roughly around the time the medical center was acquired by the UC system. We've been doing care in Anaheim since 1977. We became an FQHC. We're the oldest one in Orange County since 1985. But one of the things that I always like to point out is that that blue oval where it says BH stands for behavioral health. The government identified that our population that we serve as FQHCs do not access behavioral health services, do not like to go to psychiatry, they do not like going to psychologists or licensed clinical social workers. So what they did was each one of those lines is a grant investment to expand our services in this realm. And that is a huge win for our patients, because I hate to say this, and the reason I share it with you is because the way we structure behavioral health, so at least here in California and other parts of the country, is our psychiatrists partners typically do cash-based business. Yes, they issue the patient a bill, but they tell that patient, you manage this with your health plan and pay me up front. That is an automatic barrier to the patients we serve. And so, therefore, bringing it in-house, providing those services is a huge win. Unfortunately, that is somewhat how the structure of psychiatry is set up. So, but I digress. I wanted to share this timeline with you because we've done some really great things in our overall development here at the FQHC. Mentioned we're the oldest. We train a lot of folks, from residents in OB, GYN, Peds, and family medicine, as well as our med students, nurse practitioners, and some PA students. We are still UCI's largest primary care footprint. We took care of roughly about 2,400 patients in calendar year 2020, the vast majority underinsured or under government insurance, such as Medi-Cal. And so all this takes a lot of innovation, because we only have so much space at these two locations. And really, really important, being able to address all aspects of care, not just the medical piece. And that's the piece that's really important to understand. There are multiple facets to someone's health, and it doesn't do me any good if I can't address these other arms. So again, the innovation is great. Of course, we haven't done a group medical visit. This picture's outdated. You can tell no one's wearing a mask, so obviously this is a recent. But we do, and we will eventually get back to doing group medical visits and teaching our patients how to de-stress, how to exercise, be comfortable in their space, right? Because these folks don't have the resources to go to a 24-hour fitness, right? Or don't have maybe the resources how to go to additional counseling sessions to de-stress. So we got to teach them how to do that in order to drive their overall health outcomes in other areas. Lastly, I'll share the really exciting piece is eventually getting back online at the kitchen, because it doesn't do me any good as a primary care doctor to tell someone to eat healthy if I can't teach them how to cook culturally sensitive foods in a healthy manner. So we will reactivate our teaching kitchen, and it had great reviews from our patients. We cannot wait to reopen it. So in the end, appreciate that as FQHCs, we have a specific population that we serve, probably the most challenging population, that are dramatically impacted by social determinants of health. We've been doing it for a while, and I hope that we could be as consistent as the sun in delivering flawless care, high standard care to the most disadvantaged communities out there. And frankly, I just ask you for your help and your advocacy to do that, because there are a lot of communities still in great need. So thank you for that. I'm happy to take questions of anything we talked about.
Yep, we already do have a question.
Sure.
But just as a summary, this really outlines that there is a safety net that catches people that fall through the holes. If you joined us for Robin Flagg's talk last week, then you know that system is really surrounded by air quotes. We are really a connected network of disjointed entry points into health care. And so it's important to understand that if we're to address the larger social determinants of health, if we're meant to catch people that don't necessarily fit neatly into any other space in our healthcare system, that's where the safety net is most important. Han asked the question, how are FQHCs different from free clinics? Or is that synonymous with a community health center? Is it just that FQHCs need to meet specific criteria to get federal funding?
Yeah, so not every community health center is an FQHC, and not every free clinic. A free clinic is completely separate. So they get different designations and protections with being a free clinic. An FQHC, you do have to apply. You have to be a non-for-profit, specifically located in a medically underserved area, and it has to be run by a board of directors that's made up of 51% consumers or patients. So that's what's unique. And not every, and that type of designation, there's funding associated. We are grant funded. In other words, we get a yearly grant to operate. That isn't something that comes around very often. And so there hasn't been a open to establish new FQHCs for a couple of years now. And so there's other ways people try to activate or become FQHCs, but none officially have been announced for a couple of years. So hopefully that answers a bit of the nuance. Other questions?
I guess a personal question for me, especially in your role in the C-suite for UC Irvine, where do you see our primary care health infrastructure moving in the future?
So the primary care infrastructure for UCI is really I would say is on fast forward. So it's really interesting because there's the community practices. Now this is different from community health centers. So there's the community practices of UCI that are popping up in different cities across Orange County. That will be predominantly, again, patient facing. There's going to be very minimal teaching involved in those locations, at least at this point in time. And so that's how they're going to expand their footprint. One of the things the university has appreciated is that in order for us to take care of all of Orange County, we should also be in the primary care space. Historically, we've been the tertiary center of the county, right? I mean, we're the only academic institution. And so people come to us for our super subspecialized, world-renowned faculty position. Now, in order for us to really expand our reach in space, is really we got to go into primary care. And that is a known fact. It's been known for some time, and that's where we're headed. How we play a role in all this as a FQHC, our sites grow based on the economy, right? I mean, I think that's another thing we have to keep in mind. The way Medicaid enrollment goes is based off how the economy is going. If it's a really poor economy, there's more Medicaid enrollment and vice versa. So it kind of fluctuates. Other questions?
Okay. Well, thank you for being with us today, Dr. Mayorga. You definitely joined us for a marathon of topics covered between Medicare and the previous session and really outlining what the safety net is and means in this current one. We encourage people to give us feedback. And if you have additional questions, Dr. Mayorga is one of the most accessible C-suite members I've ever encountered. And I hope you know that it's really easy to approach him with questions, comments, concerns. So thank you for being with us for 2 out of your 3 total lectures so far, Dr. Mayorga.
You're very welcome. Thanks, guys. It's a pleasure to be with you guys. I'm talking to you in a couple of days about COVID in the Latinx community. That should be exciting talk.
Indeed.